one of the things that comes up a lot is now that we have guidelines for antiresorptive therapy for the general population, should these be modified to some extent in patients with breast cancer? Christy, how do you approach your patient with breast cancer in looking at the antiresorptive therapy issue?
Well, we all have been looking at the NCCN guidelines to at least give us clues about options for therapy. I actually have tended to go with the oral bisphosphonates for my patients, and I've really tended to wait till they're fairly significantly osteopenic before I'll initiate the therapy. I know that being on an AI and any osteopenia has indications to consider the bisphosphonates either IV or the denosumab subcutaneously, do it earlier. I am concerned that, number one, our patients are not taking calcium and vitamin D. We can talk about vitamin D levels and all that sort of thing, but they're not physically active as they should be. They're not using all the more standard ways of helping control their bone density that they could be, and to throw them into potentially toxic medication long term, I have a lot of concern about that. We're also seeing this emergence of these atypical femur fractures that are going on for patients on long term, at least oral bisphosphonates. And now that I've seen a couple of them, I have a real concern about should this be a standard long-term for patients on these medications? Do we really understand the long-term safety of patients being on these drugs?
And I think that's a message that's really penetrated into the primary care arena, because we often see our patients back who've been on an oral bisphosphonate for an extended period of time, and they come to us saying, well, my doctor told me I should stop taking this. Now I've been on it too many years. So the data to support that is still, so-so, but I agree there's data with these weird radial fractures that have been described.
And similar to, how we usually recommend, people see specialists in their field, I personally like to send patients who do have bone issues to the endocrinologist, or specifically even the metabolic bone specialists, even if it's just for one visit, because I really feel that they can really give a level of care which is superior, at least to me as an oncologist.
So another part of this equation is the replacement of calcium and vitamin D. Vitamin D is among one of the more controversial issues, not only as a vitamin that may have a variety of benefits and may lower the risk of breast cancer or breast cancer recurrence, but also just in terms of bone health. A recent study in a group of patients with prostate cancer actually found that calcium and vitamin D replacement did not help with bone mass, yet it still remains a regular recommendation for us. Also, we know that vitamin D deficiency is prevalent in the breast cancer population, and there have been some studies, although conflicting data from different studies, about the relationship of low vitamin D levels and a worse outcome. Linda, I'll give you this very difficult and controversial question. How do you monitor for vitamin D deficiency, or do you do it? And then what do you do if you find deficiency?
Well, as you may have guessed, I do like to refer to experts in the field. But frequently patients will come in and they will ask us to check their vitamin D level, and we are more than happy to do that. And if we do find a low level, we will replete it. We frequently ask our patients whether or not they're taking calcium, because I think probably some calcium is important. But we also ask them, do they do weight-bearing exercises? So for very simple management of vitamin D deficiency, we certainly are capable of taking care of it, but anything a little bit more complicated, we really do like to refer our patients out.
And the other controversial question is the use of adjuvant bisphosphonates. So there has been evidence from really early trials showing that bisphosphonates may actually lower the risk of recurrence, potentially because it modulates the bone microenvironment, which can be a reservoir for micrometastatic disease, and perhaps lowering bone turnover may make it less hospitable. And some early data that fewer recurrences occur, even going back to some of the older clodronate trials. Now that the modern generation zoledronate trials are starting to mature and data is starting to come out, Bill, do you find that there may be a subset of patients in which the adjuvant benefit of zoledronate may be sufficiently strong that you would actually recommend it, even though the studies currently are mixed and the main endpoints, some show benefit and others don't?
Yeah, that's sort of an evolving area. Clearly, as you pointed out, the sort of global data with bisphosphonates as an adjuvant are mixed. And there was a lot of enthusiasm relatively recently that would suggest that this is going to be the next adjunctive anti-cancer therapy that we incorporate. And I think probably many clinicians find a way to use it, but not calling it anti-cancer therapy. It's bone health therapy, and they get around that. But what you're really alluding to is this thread of information or data that's sort of come through many different trials now, and actually a meta-analysis of those trials suggested that in a population of patients, those that were really in an estrogen-deprived environment, the postmenopausal woman, it may be that subset of women that really benefit from the use of bisphosphonates over their counterparts who aren't in that situation. I don't know that I'm prepared to say that, you know, those are the women that should get a bisphosphonate as a component of adjuvant therapy, but those also happen to be the postmenopausal women that probably need a bisphosphonate to a large degree for their bone health. Whether you give it orally, IV, I don't know, but I don't routinely add a bisphosphonate simply as a component of adjuvant therapy.
Well, I think the other thing we saw at the ASCO presentation to overview the use of adjuvant bisphosphonates was the concern that the risk of recurrence was actually higher in the younger women who were just perimenopausal, perhaps, or women on the AZURE trial that were not very far from their menopause, so, or were premenopausal, and the concern about harm there needs to, we all need to be aware that there's that suggested there. I think the hazard ratio is 1.3 something for the younger women being given the bisphosphonates. So it is not clean data. I mean, I think it's really trending in every one of the trials that's been looked at in significantly postmenopausal women, at least 5 years out perhaps, seem to have benefit with risk reduction of recurrent breast cancer, but I think there's still this risk of harm for the other groups.
And I think it comes back to, just like we make choices about systemic therapy, you know, what is the risk? And I think if you have a high-risk adjuvant, probably the risk is less with a bisphosphonate added. And certainly the zoledronic acid data is great, but I tend, even though there's that tiny little percentage chance they can get the ONJ, that's not a complication you want. So I tend to give oral bisphosphonates for the high-risk population. But I do a lot of high-risk breast cancer, so it's not as tricky.
I've been using a lot of the denosumab in the Prolia formulation, which is the 60 milligram sub-Q, twice a year because of the Georgiana Ellis randomized trial with aromatase inhibitor therapy in the postmenopausal adjuvant setting, you know, plus minus the sub-Q denosumab, showing really nice improvement in bone density, and it's fully FDA approved. And you know, I've really got to believe that the safety of that, given that the Xgeva formulation is quite safe with the higher dose monthly, that the risk has got to be extremely low. Although I take your point. I think that over a few years on these agents that are antiresorptive, giving the bones a break to have some normal turnover is a good thing, and then maybe resuming them down the road. But I do use quite a bit of the denosumab sub-Q because of the nice improvement in bone density when people get to be osteopenic.